all the memory of rainy afternoons, swingy Harlem tunes, motor trips and burning lips and burning toast and prunes. How lovely it was. Thanks for the memory of candlelight and wine, castles on the Rhine, the Parthenon, and moments on the river line.
Just the last name of the day.
How lovely it was. Many's the time and many's the time we fasted. Oh, well, it was swell while it was.
Okay, welcome back, ladies and gentlemen. Hopefully you had an enjoyable lunch. Our 1 o'clock speaker for today is Sam Dreeben. He's a physician, PhD from the Palliative Care Psychology Fellow from South Texas VA. Right here. This is your home office. This is your house. So please welcome one of your own, Sam Dreeben. Thank you.
Thank you so much for having me here today. I've been looking forward to this. I'm going to be presenting on the biopsychosocial model in end-of-life care. I'm a palliative care psychology fellow, and so we're going to talk about this model that we use frequently within psychology and how it might apply to some of the patients that you all see. For today, our objectives are to use this model to inform treatment in end-of-life, to understand what some of the goals are of palliative care and hospice services, and to describe your role in addressing the psychosocial, physical, and spiritual needs of patients at end of life. And so while I'm going to try and present how we might conceptualize end of life patients from the psychologist's perspective, my hope is that as I'm talking about this, we'll kind of take a more transdisciplinary perspective and think about how this could apply to everything that we all do in ways that we can offer these services for our patients. So I have a little vignette that I wrote. I kind of drew, or kind of created a composite of different patients that I've seen. So if you'll bear with me, I'm going to read it. My hope is that this will kind of tie everything together. I had my wife read it, or I read it to my wife the other night, and every time she said, ugh, then I took that part out and changed it to something else. So hopefully it's a little better now. So Mr. Smith was a 70-year-old Vietnam War veteran who was diagnosed with a malignant brain tumor. Previously, he'd been in good health. Mr. Smith identified as a fighter his entire life and insisted he was willing to do whatever it took to return to health. His oncologist explained the tumor was too large to effectively treat with chemotherapy or radiation, and the location of the tumor would make any operation fatal. We can manage your pain and some other symptoms, but I'm so sorry. Other than that, there is nothing more we can do. Okay? So this may be dialogue that you've heard of or been part of. My hope is that this patient sounds familiar. I know in particular for the people who work here at the VA, I imagine he will. What I'm hoping to get across today is that this idea that we are all healers, and that our goal is to heal our patients, that role doesn't end the moment a terminal illness is diagnosed. In fact, a terminal diagnosis can be where healing begins. And I really do mean healing. When we talk about end of life, we often talk about comfort care, which is a really important part, and we're going to talk quite a bit about it. But the idea of comfort sometimes, I think, suggests that there's no longer the possibility of any sort of healing. And I'd like to put out there that, yes, there is in fact the possibility of quite a lot of very important healing that does happen towards end of life. And it's something that we can all be a part of. So back to Mr. Smith. Mr. Smith's wife of 50 years knew to get out of his way when he was in one of his moods. He was a stubborn man, and he did not accept defeat easily. She knew he had agreed to meet with the palliative care physician, Dr. Lopez, at the VA, as a courtesy to his oncologist. But she did not expect the meeting to go well. As she predicted, Mr. Smith promptly accused Dr. Lopez of wanting him to give up and die. My goal is to help you reach your goals, Dr. Lopez said. Why don't you tell me more about what you want out of the care you're receiving? So we're talking about end of life using this kind of broader model, the biopsychosocial, spiritual model, or which we often use in palliative care. The piece that's really at the top in my mind is how can we honor our patients' wishes? This requires a lot from us as providers. Oftentimes, our patients' wishes aren't the first thing that they're going to tell us. It takes some patience, and it takes building some rapport and getting to know what it is that's really important to each of our patients, what creates meaning in their lives, and maybe what isn't right in their lives and how we might be able to help them remedy that. We're also thinking about what their quality of life is and whether there's any ways that we can improve it, any ways that we can help them improve their own quality of life. And of course, when we think of end-of-life palliative care, we're thinking about alleviation of pain and suffering. I do want to make the point that when we're talking about pain, the first thing that comes to mind is physical pain. And certainly that's at the top of everybody's list when we're thinking of people who are in tremendous physical pain, tremendous suffering. But I would posit that the emotional pain that people experience at end of life is every bit as painful, if not more so. That any of us sitting here in this room, really severe emotional pain will cause us as much suffering, if not more so, than physical pain. For those of you who like to look up research, there's a really interesting laboratory at UCLA. I know one of the principal investigators is Naomi Eisenberger, who's looked at the shared neural pathways between physical and emotional pain. And increasingly, we have the sense that people really do hurt when they're in emotional pain. Now, I think that it's important for us to bear in mind that the type of pain people feel is very real when they feel lonely, when they feel hopeless, when they feel depressed, when they feel anxious. And they were making a really substantive difference in their lives when we can help them work through that. And then finally, this idea of a good death is very important. We're going to talk more about what that might be. So I wanted to show you this diagram. I think it's a really useful way of conceptualizing what palliative care is and hospice care. Oftentimes we equate the two as one and the same, and we think palliative care means that someone is actively dying. Really, palliative care can begin at any point when someone has a terminal diagnosis. You could be on palliative care for many years. And it can be that towards the beginning, there's very little that's being done with the focus of quality of life, reduction of pain and suffering, and that most of the treatment you might be receiving is life-prolonging therapy. It is curative. It is creating, more health, helping you, fight whatever this difficult diagnosis is. Over time, though, as the disease progresses, we expect that the needs for palliative care become greater and greater. And over that same time, we find that there may be less and less that we can do to prolong someone's life, to the point that eventually we're at hospice, which is a prognosis of 6 months or less to live, and we're looking really at how can we improve quality of life and reduce suffering, reduce pain, and improve symptoms. So as we're talking about this, think about this disease progression and where some of these interventions might be applicable. Those of us here at the VA or associated with the VA, very much on the cutting edge of palliative care treatment. And I'm sure as this conference progresses, everybody will point out that there is this amazing increasing need for services for older adults. And of course, when we're talking older adults, there's a higher likelihood of terminal and end-of-life issues that come up. So here, through the VA, we do now provide palliative care consultation services in all of our medical centers. Many of our community living centers, which we have one here, and we do have hospice services that which is one of the rotations that I've served on this year. And we have contracts with many community-based hospice programs so that now we can say, this statistic I have is from 2008, so this may be greater by now, but over 60% of all veterans at that time who die in VA facilities receive care from a palliative care team. So we're very much integrated, and thankfully it's very much a priority for the VA. So as we're thinking about what kind of issues come up, I'm going to read this next vignette. I'm not going to wear diapers and be fed like a baby. Dr. Lopez listened carefully to Mr. Smith and reflected back Mr. Smith's concerns. We can help you maintain your strength and independence for as long as possible with help from physical therapy and occupational therapy. Is that something that would interest you? I wrote this bit to maybe bring up the possibility that some of these treatments that we think of as rehabilitative, as getting from point A to point B, of becoming 100% cured, that they're still applicable for our end-of-life patients, and that as people are facing a lack of control, a lack of autonomy, feelings of helplessness, hopelessness, that services like PT, like OT, and certainly some of the services we have available specifically for our veterans through the VA, where we have home-based treatments, that they can make a huge difference in a person's quality of life, not just on a physical level, but on an emotional, psychological level as well. So, the title of the presentation was the biopsychosocial model. Sometimes it's referred to as the biopsychosocial spiritual model, and I do intend to incorporate that today. This model of healthcare was introduced by George Engel, and it's not just intended for palliative or end-of-life care. It's really meant to be a way of looking at healthcare across the spectrum and incorporating not just curative, physical, there's something wrong with your body, we're going to fix it type problems, but looking at the person as a whole being that has different needs across all these different domains. And here's one way of looking at it. We're going to dive a little bit deeper into each of these domains as we move forward. We have the biological and physical needs of our end-of-life patients, the social needs, the psychological, and the spiritual. And no matter what discipline you're in here, I'm going to suggest that these are relevant to each and every one of us when we're understanding what the needs are for our patients. So, for instance, as we're thinking about functional ability in the biological, physical realm, that's very relevant on a structural, physical level. But if you've been able to care for yourself your entire life, you've been independent, maybe everybody's always relied on you in order to be the strong one, the one that they were cared for by. If suddenly you're not even able to care for your most basic needs, for your bathing, for your toileting, for your feeding of yourself, that can have enormous impacts, not just physically, but on how you view yourself in relation to other people, how you feel psychologically, how you feel emotionally, and it can have an impact on your relationship to the meaning in your life, to your faith or spiritual sense of how everything fits together and where you fit into in the grand scheme of things. And we could go through each of these, and we will, and see how this isn't a model that so much says that there are many different domains we need to be assessing, but it more speaks to the fact that there is an interconnectedness to all these different ways in which end-of-life issues impact a person. And we as clinicians are working with these patients. It's our job to understand the interplay in order to be able to better serve. So as we're thinking about different symptoms, particularly as we're doing maybe an initial intake, might be understanding, like a history or understanding the basic medical issue that the person is coming in with. Here's some ways that we can be thinking about how to assess those symptoms. So understanding when it began, because there's a big difference between someone who's had a chronic illness where they've learned to incorporate that illness maybe into their self-identity, or they've maybe even developed certain types of coping strategies to deal with the chronic illness, as opposed to someone who had an acute medical event and suddenly they're in hospice care, or they're suddenly requiring 24/7 care when the week before they were taking their grandkids to school and they were fixing the Sunday meal. It makes a big difference in understanding what that person's needs might be. So that, in terms of duration too, how long have they had to be dealing with this? What is the quality, let's say, of their pain? If someone has a pain that is an ache versus a pain that feels like a stabbing, how might that impact the way they're able to concentrate, the way they're able to cope with going to sleep, how it impacts their relationships when they're trying to spend time with their family or people who matter in their lives. What are the aggravating and relieving factors? Sometimes I think we get the sense that we have all the answers, that if they would just listen, we're going to tell them how to cope with pain, how to cope with their depression, their anxiety. It might be that they've developed some very effective or at least useful type coping strategies on their own. Or it might be that they've developed some that could use some coaching or adaptation. And we want to understand where they're coming from. It's also a matter of respect and understanding that each of our patients bring their own personal wisdom and insights into their own care. And it fits into that model of treating the person with respect and dignity, which oftentimes I think is one of the most important ways that we can help the healing process happen at the end of life. What are associated symptoms? What is the relationship between these symptoms? How has their quality of life been impacted? That is to say, is there anything that brings them pleasure at this point? Is there anything that they look forward to? Are there ways that they used to find meaning in their life that have been stripped from them? And if so, how can we help create that in whatever amount of time they have remaining? Their functional status, how much can they do for themselves? And then broadly speaking, thinking about all these different variables that we've started to touch on: social, cultural, emotional, spiritual, and how they impact. Cultural variables can make a huge difference in how people approach end of life. Spiritual, religious understanding of end of life, understanding of how one is supposed to cope with pain and suffering. And if we go in and assume that, say for instance, that the only thing that matters is to get this person's pain under control, well, oftentimes it might be that someone sees that pain as a dignified pain, or as a pain that creates meaning for them as a way of approaching end of life, or as part of the life cycle. And if that's the case, we don't want to overlook that, just as one example. Okay, so we're back to Mr. Smith. Despite palliative chemotherapy and physical therapy, Mr. Smith grew weaker and became increasingly dependent. The tumor had grown. Mrs. Smith, a petite woman, struggled to physically care for her husband, even with the help of home health. Splitting headaches left Mr. Smith in tears, and his typical can-do attitude was no longer on display. When they met with Dr. Lopez again, Mr. Smith and his wife were visibly exhausted. Maybe it is time we re-examine what you want. There's a sense that I think we can have sometimes that once we've done an assessment, once we've understood where someone is psychologically, maybe spiritually, physically, that should define the treatment that we move forward with. Particularly, I think, with end-of-life patients, as they're faced with new stressors, new limitations, new developments in the course of their illness, that can change very rapidly, and it can change many times. And it underscores, in my opinion, the importance of being in a constant stream of communication, developing rapport, learning more about that patient as they move through the course of that illness. For instance, someone may be undergoing palliative chemotherapy, and that may have been by far the best decision for them at the time when they began. If they're feeling weak, if they're feeling sick and nauseous, maybe that changes as they realize that there's not much that they're getting from it, and that there's a lot of side effects to contend with. It's dangerous if we assume that what was good for them at the beginning is necessarily good for them later on. And so that is one thing to keep in mind as we're working through our relationships with patients over time. So I was going to just touch on this first of the kind of 4 layers of the biopsychosocial and spiritual model. Think through how this might help us conceptualize our patients' needs. So oftentimes if you work with older adults, particularly those near end of life, we see changes in appetite. And that can be very confusing from a clinical perspective. Appetite changes could be the result of depression, of dementia, of anxiety, and not really, unless we can get a good interview with the person, can we understand why it is that is changing. Of course, we know that as food intake decreases, that can have a really striking impact on a person's stability, on a person's ability to cope and thrive. So we're always thinking about what that means. There's decisions, too, that our patients need to make. For instance, whether or not they want to be put on artificial nutrition if they're no longer able to feed themselves, or they're at risk of aspiration. That can be a huge quality of life decision if someone doesn't want per se, like a peg tube or something in place. There's the issue of pleasure eating and the risk involved. For some of our patients, there is no greater joy than a cheeseburger. And it may be that they're willing to take the risk of aspiration in order to experience that. What can we do to facilitate that? What risk, how can we educate them? How can we find common ground to make that possible for them? In some cases, it is kind of a waiver of liability that they sign. In other cases, it may be education that they don't realize how dangerous this really could be. How badly do you want the cheeseburger? That's an important conversation to have. Also talking about whether they want, kind of reconceptualizing food, not necessarily as something for pleasure, but as something to keep their strength up. If food no longer tastes good, if because of the treatments they're undergoing it has a metallic taste, or they lose their appetite, how do we work with people to help them continue to be motivated to eat in order to help their treatment, even when it's not rewarding per se to eat like they once did. So all things to consider. Of course, pain management, understanding what our patients' pain needs are. That could be understanding from a pharmacological perspective what's working and what's not, what side effects they're willing to experience and what they're not. But also, and I'll put this plug in as a psychologist, the first line of pain management should always be non-pharmacological. What can we do on pain management? Can we teach relaxation strategies? Can we teach cognitive restructuring to reframe how patients experience and mentally their pain. What can we do as far as social support, behavioral activation, getting them active? How can we change the experience of pain, making sure that we're providing those? Sleep, too, is something that is very erratic at end of life. We know things like pain, things like new settings, and the anxiety that can come with it can be a huge impact on sleep as well as depression. So before we jump to any conclusions, really understanding what it is that impacts that person's sleep patterns or disturbances, and figuring out what the cause is, and by extension what the solution is. Offering education about proper sleep hygiene and finding the right treatments for them. And then other common physical problems like constipation, nausea, dyspnea, fatigue. How are those impacting how that person feels about their end of life? How does it make them feel about their ability to cope? How does it impact their ability to be with family members? It may be that if, let's say, incontinence is a problem, that it's really hard for them to receive the social support that they may so sorely need. How can we work with them on that and be sensitive to the very real emotional pain that can come with all these types of physical ailments? And how can we create a home-like, comfortable environment? So this is Rick. Rick knocked on the door. Good morning, Mr. Smith. I'm the recreation therapist for the hospice unit. Just wanted to introduce myself since I saw you were new here. Mr. Smith nodded his head but continued staring at the wall. Just so you know, we have a volunteer playing acoustic guitar later tonight. We would love for you to join us. Mr. Smith continued staring straight ahead. I'm more a Stones fan myself, Rick admitted, but we couldn't book them tonight. Mr. Smith turned to look at him. Have you ever seen the Stones live? The veteran asked. Just about 20 times, Rick replied. Say, would you be interested in listening to some albums if I could find a CD player for you? Some of the most effective end-of-life interventions that I've witnessed have been things like getting audiobooks for patients who can no longer read to themselves, finding music or pictures, creating some sense of normalcy in an environment that is very much not normal. And in this case, it's taking the time to understand that something that brought this gentleman great joy before might be of great comfort to him as he approaches end of life. And there's a lot of ways that adjustment can be very challenging. Imagine most of you all are familiar with Kubler-Ross's stages of grief. There's not just grief that the families experience for the loss of a loved one. There's anticipatory grief that our patients are experiencing. And it is about the loss of life or the future loss of life, but it's also the loss of independence, and it's the loss of self-worth, and it's the loss of relationships. We grieve the things that we lost, and for each of those, we can experience these range of emotions, the denial, the anger, the bargaining, the depression, the acceptance. Recognizing those, and they may be in different stages of grief, on different levels of, on different domains that they're grieving, can be really useful, and not being too put off when we find out that someone's angry that they lost these things. I think it's really easy for us to get the sense that our patients are these objects for us to study, and if they're angry, well, maybe we should give them something to calm them down. What I would hope and suggest, and what I think is best for our patients' well-being, is to think in terms of what they're experiencing and what this must be like from the inside out. And anger is a totally natural response. Tears are a natural response. Depression certainly can be a very natural response. As they shift through their stages of illness, how they perceive their illness and the prognosis that they have can also shift dramatically. There can be all these stages of grief related to, denial that I'm sick, angry that I'm sick, saying I'll do anything not to be sick, feeling hopeless, and then eventually accepting. And we can shift back and forth through those. It's not necessarily a linear arrow through those stages. Being sensitive to that also can help people feel understood rather than feeling like there's something wrong with them, rather than feeling like this process is pathologized and something that we need to fix. In a very paradoxical way, one of the ways we can fix the distress that people are experiencing is by practicing some acceptance and normalization of that very distress. As funny as that may feel in the moment. We talked quite a bit about functional abilities, but recognizing that there is an adjustment to not being able to care for yourself, or not being able to do the things, perhaps provide for your family, provide for yourself, care for yourself on a very fundamental level. And then recognizing too that there's a lot to fear about this process. And some of our veterans in particular, but this is true no matter where you work, some of our patients are people who've been very strong. And with our veterans who've had to face incredibly fearful experiences and have been taught to be stoic and brave in the midst of great fear. And they may be experiencing some of these emotions, but it might be just below the surface. So it might take a while for them to come up in a very transparent way. They may manifest in other ways in the interim. So anxiety about what's going to happen when I can do even less for myself than I can now. Anxiety about what's going to happen when the pain increases, when the tumor grows larger, when my eyesight goes even further, when the headaches grow worse. How am I going to cope with that when that time comes? If a patient is on an inpatient unit, that's social isolation, or even if they're stuck at home and they were used to having a community where they could go out and be with people, maybe a church community, maybe community organizations of friends that they saw regularly. What does that mean to suddenly be isolated from all the people that create meaning in your life? And how can we create some social support, some network in this more artificial environment? And recognizing too, in particular again within patient settings, the stress that comes with being relocated from everything that you knew, from everything that brought you comfort, your home, your routine, and being dependent on other people and other people's schedules, being dependent upon other people to provide for you when you need something. And how do you deal with that uncertainty? I don't know if you're like me, but uncertainty is not a very comfortable feeling. And you have to imagine that some of our guys are experiencing just tremendous levels of uncertainty and lack of control while they're going through this. So this vignette says, I can't sleep in this place. Dr. Wynn, a psychologist, met with Mr. Smith to learn about his sleep patterns. Mr. Smith reported no difficulty falling asleep and noted he could sleep no more than an hour or two at a time. He complained of noises in the hospital, including other residents, people talking in the hallways, and helicopters landing outside. When asked, he admitted sudden loud noises and helicopter sounds sometimes triggered combat-related nightmares. With Mr. Smith's permission, Dr. Wynn helped facilitate a bed transfer to the opposite side of the unit, away from the hospital helipad. The nightmares remitted over the course of a week. So as a psychologist, normally the first thing I'm thinking about is poor sleep hygiene and how I might help someone with that. But there can be even more basic needs that a person has, and understanding how the environment interplays with their emotional and psychological adjustment. This case illustrates that it can be entirely unexpected, contributing factor that can make things really difficult. So being patient and understanding what each of our veterans individually is going through can make a really big impact. I want to talk a little bit about psychological adjustment. Looking at depressive symptoms is really tricky because we expect some sadness at end of life. We expect that there's going to be some hopelessness. But we don't want to be biased to thinking that just because someone's dying, they're going to be depressed. And oftentimes we don't see that to be the case. I would imagine very little, or I can't imagine much worse than being treated like there's something wrong with me, like something is pathologically wrong with me, when really I'm feeling pretty good about the way things are. And sometimes we do find that with our patients, that they're really well adjusted. So being sensitive that not everybody's depressed, and for some people we might think are depressed, who become sluggish, who have somatic symptoms like sleep disorders, appetite problems, who are physiologically slower, that doesn't necessarily indicate depression either, that can be a physiological change, and being able to parse apart what that is. To the same extent as we don't want to treat everybody depressed, we also don't want to treat everybody as cognitively impaired. I'm sure you all are familiar with kind of the seniorese that we do. We talk really loud and really slow so that our patients can understand us. That can be really offensive if someone doesn't have a hearing problem and they can understand just fine. What I've noticed in some of my clinical interactions is one of the most potent clinical interventions is to take someone, say, who has expressive aphasia, maybe they've had a stroke, they're not able to communicate like they once were able to, and everybody comes in and talks to them as if they're an infant, or as if they can't hear, as if they can't understand. They can understand perfectly fine. Taking the time to treat that person like an individual, to treat them like the adult human being who's had a rich and meaningful life, who's done all these amazing things, who's had a family, who's had a career, and to talk to them with an interest in who they are and what's important to them, even if it takes a long time for them to respond. Even if they can't respond, but they would just like to feel like a normal person again, that can make a huge difference in the quality of life in a person's day-to-day living. Of course, when we're looking at cognitive impairment, we do want to make sure that we're delineating between the dementing process versus something like a delirium or a pseudo-dementia, depressive type presentation. And two, we're thinking in terms of quality of life. So what can we do to make their day-to-day life more enjoyable, to give them more control? How can we help them perhaps with memory, by having aids, by repeating directions, allowing time to process, respond? And how can we communicate this to the team? So as you all are getting this wonderful education this week through the symposium, how can you bring this to your teams and educate everyone about how we can be more sensitive to the needs of our patients? I want to touch briefly too on substance use, which we don't always think of when a 90-year-old patient comes in and they're in the dying process. But it can make a huge impact on how they experience that time. So say someone has been drinking a 12-pack every day for the last 50 years. Suddenly they're put into a new environment. They're dealing with little control. They're dealing with the fear of an impending death, a prognosis of, say, 6 months or less. And we're taking away the only coping mechanism that they've ever really used. What do we expect to happen? And should we be surprised when they have a really hard time coping with this change? Being extra sensitive to those patients, being extra sensitive to a person, say, who has a history of opioid drug abuse, and we want to put them on opioids for pain control. They've been going to NA for the last 15 years. How dissonant that might be with their value system, and what an affront that is if we force that or push that on them, when it would mean to them that they had relapsed and had lost all of this important sense of self-worth and efficacy that they've worked so hard to gain.
Can I ask?
Yes?
Is medical marijuana
marijuana on the horizon to help?
Is medical marijuana on the horizon to help? I don't know the answer to that. I might.
I'm just curious.
I see a pharmacist in the yay, nay.
Probably.
Probably. The answer is probably.
Okay.
That makes sense to me.
But that,
So,
it would be used like medication. It would be prescribed.
right. So
That's why it's medical. That's why I said medical.
Right. It
we
would
had, yeah, it would be used as medication, and frankly, we do have medications that have powerful effect on not just pain, but it affect our mood, our thinking, and we do prescribe those, and we have to think really carefully. Of course, I'm not a prescriber, but we're always thinking carefully about how that might impact a person's quality of life. It's no coincidence that opioids that we prescribe for pain are highly sought on, outside of a medical setting. It's not just because there are a lot of people walking around with chronic pain. It makes you feel good. It numbs a lot of emotional pain too. And so because they work on similar systems, it's something we have to be really careful about. All right. You don't talk much about your family. Yvette, Mr. Smith's nurse, knew him better than anyone on the unit. As he lost the ability to care for even his most basic needs, it was Yvette who cared for him with respect and with kindness. It was Yvette who listened to his stories, who let him know he still mattered. Her comment this time, though, caught him off guard. Mr. Smith was estranged from his daughter, and it was clear thinking about her was painful. Yvette asked if he would like help writing a letter to his daughter. Mr. Smith said no,
How'd you fix that?
but 3 days later, he let her know he had changed his mind.
HTO3. You see
Oh,
that?
yeah.
No, I think it's wrong.
Yeah, you just gotta wait for a second.
I think there's a microphone on the detail. It was very interesting, though. Okay. So thinking a little bit about social issues, I've touched several times now on how losing a sense of control, a sense of efficacy is maybe one of the greatest losses to our patients at end of life. One really important way that we can empower our patients is through advanced directives and living wills. Helping them to have, and we hope that we get them at a point where this is still possible, but helping them make decisions about their care and how they would want their lives, their end of life time to play out can be very empowering. It's also a great gift to the families and the people who care for them, who aren't saddled with the responsibility of making these decisions, which are very, very painful when you don't know what the person would have wanted. So we make a point of that. I know here at the VA, and I hope wherever you work, that you emphasize that in your practice. It's not just, though, medical decision-making and code status that impact our patients' lives. It can be their finances. It can be worrying about relationships that are broken, or other burdens that weigh heavy on their souls. I know for some of our patients, finding a fiduciary, someone who can care for their finances, was one of the greatest pieces of care that we could provide, because they didn't die fearing that their family wouldn't be cared for, fearing that their finances would build up, amount over time, bills and overdue fees. No one wants to leave their family in a bad spot, to leave their heirs in a bad spot. And that's something to be thinking about, even though it's uncomfortable sometimes to talk about finances of somebody who's not, your spouse or someone who you know intimately. This can make a huge difference just by asking that simple question. We see too that end of life is sort of like weddings or births. If there's family stuff going on, it's gonna come out at end of life. It's not all roses and happiness and beautiful. There will be families yelling at each other. There will be conflict. There will be people fighting over money. There will be people fighting over property and what's going to happen to mom or dad at end of life. And we know this is a huge stress on our patients. And being ready for that and prepared to help facilitate some of those conversations and, find the appropriate resources, whether it be a therapist referring to psychology, finding who can help out with some of these family systems. To that extent, too, just the stress that's placed on caregivers. We talk a lot about caregiver stress and recognize it as important because it's an enormous burden to care for somebody that's sick. But sometimes I think we forget it's a burden on the sick person to know that someone they love is burdened like that. And so this is a patient care issue. It's not just some auxiliary service that we provide. Helping the caregivers get the support they need, helping them work through some of their issues, and providing support through our services can create a huge emotional and adjustment type benefit to our veterans. Our patients experience role changes that are very dramatic at end of life. Going from being a provider to being totally reliant, going from being a parent to being in almost a childlike state, going from being, this brave and powerful person that everyone viewed with, respect and awe, to someone who is, fragile and frail and can't even take care of the most basic needs in their lives. If you stop and think for a moment how you define yourself in your life and what that would be like if that was totally taken away from you, it speaks to what a jarring experience this can be. And also to the extent that we can treat our patients with respect and dignity, we can get them back some of what they've lost. Not never entirely replicated, but give them some sense that who they are, who they were, what they bring, what they still know is of value and meaningful to us and worth valuing in them. On a really basic level, things like appearance can also affect how that person feels about themselves. This is a person who's always shaved and bathed, and they have to go a week without a bath, and they have a scraggly beard, and they start to smell a little bit, and they're wearing hospital clothes. Think of how that makes you feel if you haven't had a bath in a couple of days. I'm not saying that you all do that, but just theoretically, if you didn't bathe in a couple of days. Imagine how they feel stuck in a bed like that. Imagine how they feel not having the dignity of looking that way. It can make a big difference just getting a haircut. And if someone, to the extent that we get value too out of our own sexual functioning, our sense of ourselves as sexual beings in relationship with others, if that's taken away, a person can feel like they're no longer of as much value, that they're not participating in some role in their relationship or some satisfaction that they were able to get at a previous part of their lives. We can be really uncomfortable talking about that. Sometimes it is a relief just to have someone to talk to and not to be made to feel ashamed or to feel different because of the fact that you might be grieving this loss, or this adjustment. Mr. Smith was raised in the church but had never gone back since returning from Vietnam. When the hospice chaplain introduced herself, Mr. Smith told her immediately to leave. The chaplain looked at him with kindness, thanked him for his military service, and set her car down by his bedside. Before she could leave, he stopped her. "How can you thank me for my service when you don't even know the things I did?" "You're right, I don't know. Are you afraid of what I would think if I did?" not afraid of you, but I should be afraid of God, don't you think? I know we have some chaplains in here today. Oops. I know in my training, though, as a psychologist, we don't talk about faith very much. In fact, it's out of our scope of practice. It's something we're very careful about. I think it would be very short-sighted, though, to not recognize how big an impact this can have on a person's end of life as they face death, as they create meaning, or as they grapple with lack of meaning in their life. When everything made sense before and now they're wondering, why me? Why is it happening like this? This is not how I wanted it to be. This is not how I'm supposed to go. Why am I suffering? Those questions matter. And whether or not you're in a position to counsel someone on a spiritual level, to be available and willing to hear those concerns and to create space for it can be an incredibly powerful experience. These issues plug into a person's value, a person's dignity. We want people to have meaning just for the sake of their adjustment, but also their humanness. We are meaning creators as people, and if our meaning gets taken away from us, that's when hopelessness sets in. And so finding space to find out what matters to a veteran and how we can help support what matters in their life, I think is maybe the most important thing from this whole presentation, is what matters to you. I would say, too, that there's a very selfish motive that you can approach this with, in that I get a lot from hearing what matters to people at the end of their lives. For me personally, it kind of strips away all the other stuff in my life and helps me see things a little bit clearer. And I hope that if I can bring that attitude to my interactions with these patients, that then I'm offering them a level of respect and dignity, because they do have something to offer. They do have an understanding of their entire life's arc and what mattered to them in it, what matters to them now. And just by listening, I can help them make sense of what matters to them moving forward and allow them some semblance of dignity in the process. I hope we can all make a point of that as we're approaching these patients. Thinking about what suffering means, thinking about guilt. It often comes up towards the end of life. And I think our first instinct is to want to resolve it right away, but to give that person space to say, I'm not settled with the way my life was, and there's things that I wish I'd done differently. It's very uncomfortable, but just giving voice to it sometimes can be a healing experience in and of itself. Allowing moments of redemption, allowing a person to explore their own spirituality and religiosity, and to have some experience of transcendence beyond their very physical, earthly existence, and to key in to bigger truths in their lives and what matters on a grander scale. He would never let me do this for him before. Mr. Smith's wife wiped the sweat off his brow and stroked his hair. His tired eyes communicated his affection for her as he now struggled to form words. Are you ready? The social worker pulled the laptop up to Mr. Smith's bed and connected to that telehealth software. Mr. Smith's daughter appeared on the screen, sitting in a VA hospital across the country. She had received a letter he sent. Hi, Dad, she said, with tears swelling in her eyes. We can't make these things happen, but we can give the space for healing to occur. And we can help facilitate a good death. Not everybody will have a good death. I don't want to be too Pollyanna-ish about this. Some people are going to be resistant, and they may die angry, they may die bitter. But we want to give them an opportunity to resolve some of that. I think it's an issue of human dignity, and I hope that if I'm on my deathbed, that there will be space and care given to me to work through some of these same things. So one model of a good death, just to kind of recap this in a slightly different light, was proposed by Emmanuel and Emmanuel. And you can think about these domains as you're working with people towards end of life. A good death involves physical symptoms being under control, things like pain and fatigue. Psychological and cognitive symptoms like depression, anxiety, confusion, helping with those to the best of our abilities. Creating social relationships and support that are meaningful. Helping lessen the economic stress or financial concerns and the caregiving needs that our patients have. We've had many patients who are worried about the financial impact of end of life and wanting to help them however we can get the resources they need, the support that they need in that way too. Helping them with what their hopes and expectations are for the time they have left for their families after they are gone, and for allowing them the space and time to process their spiritual and existential beliefs about what this all means, where they're going, and how they can create meaning out of a very difficult situation. So this is why I care a lot about this and made this, my own professional interest. I am kind of a sappy person, if you can't tell by the vignette that I made by nature, so maybe this fits my personality pretty well. But I also care a lot about providing service to patients, of creating value for them in a way that they feel that their needs are being met. And I do believe that this model, looking at all these domains, the bio, psycho, social, spiritual model, does just that. And it moves us in the direction of thinking about our patients as whole people. So we think about what their values are, we have those conversations, and we help them understand, because just because you have a value doesn't mean that you're necessarily living a life consistent with that value. And we give them an opportunity to feel the satisfaction of making decisions at end of life that are consistent with what they really care about, helping them feel good about what it is that they're doing with their time, their resources, their energy, with the limited time, resources, and energy they may have left. Second, be focusing more on family, faith, community, their own legacy. We do legacy projects for our veterans sometimes, so it might be helping them make a recording for their family, for their loved ones, about what matters to them and what they want to share. It can be about being philanthropic, somehow giving back and connecting in a way that transcends all the suffering and limitations that they might be experiencing. Focusing on goals that these patients have. There's nothing like lack of time to help focus in on what really matters and set some of those goals. So how do you want to spend what time you have left, given what you can do, and what still needs to be resolved? And what can we do right now while there is still time? And then lastly, these are the three questions that guide my treatment and my service to these veterans. And they are you comfortable? What matters most to you? And what are your wishes? And I think if we're spending time thinking about those, the moment our veterans get a diagnosis, a terminal diagnosis, instead of thinking of it as how can we just keep them comfortable, how can we reduce how terrible this is, if we think of these, we can start thinking of how can we make this the most productive, meaningful, valuable time that we possibly can. Maybe this is their last opportunity to feel good about the way they've lived their life and the way they are connected with their world around them. What is it that we can do, and can we provide them with that sense of meaning? I hope it's a positive view of what end of life can be. I hope it's a view that provides dignity and a sense of interacting with each individual as someone who has the answers within themselves, but can rely upon us as care providers across disciplines to help make that value system and those wishes and hopes a reality. So that's the end of my presentation. If you have any questions at this time, I would be happy to answer them.
Okay.
Yes, ma'am.
You're doing your fellowship now, you said?
Yes, ma'am.
What was the most exciting, unexpected thing that's happened to you, and what was the saddest?
Oh, geez. The question was, on my fellowship this year, what was the most exciting thing that happened to me, and what was the saddest? You know, there have been a lot of each. A sad one comes to mind first, and then maybe I can come up with an exciting one. And I'm sure afterwards, there have definitely been a lot of exciting ones too, but let's start sad and end on a high note. There was a gentleman we had who had Korsakoff's dementia, so alcohol-related dementia. He actually presented as fairly with it, but if you spent time talking to him, and we actually did an assessment of his cognition, we realized that his memory was, for his age, was at below the 0.1 percentile, severely impaired memory, and his ability to care for himself was incredibly poor. When he came in, he had been living in a trailer with cockroaches and mold on his food, and was in really bad shape. And he had oral cancer. So he came in, and he was in total denial and unable to understand fully that he had this cancer. And he wanted very, very much to leave, and was fairly clear about his intentions, which was he liked to go back to drinking, which was his one way of coping with the suffering in his life. And we had the responsibility of caring for him and not letting him go and really, quickly deteriorating is what would have happened. He was incredibly unhappy about that, very unhappy. And while we took very good care of him, it was hard to see him suffer. And as his disease progressed, he developed these awful tumors and became very debilitated. And he was unable to get any sort of closure or peace about his dying process. And I think he died very unhappy, to be honest. We did the right thing. It was our responsibility as care providers not to put him in a situation where he couldn't even take care of himself in the most basic way. But it's sort of the antithesis of the vignette that I presented today, in that he wasn't able to get any resolution. I think that's what pains me the most. There have been other veterans who, one comes to mind, he'd been an alcoholic for many, many years, and had a kind of an aha moment, started going to AA, and had become this pillar of the community. Not just the AA community, but I got the sense, like in all of San Antonio or something, he had decided to change his life, and he devoted his entire life to giving back to others. He wanted to make up for the time that he had felt like he lived so much of his life selfishly, and he wanted to be giving. And as he was in hospice, there was this parade of people that were coming in to see him, and his wife had to act as a sort of bouncer because there was too many. He couldn't handle it. They all were coming to tell these stories about how he had changed their lives. And he still wrestled with these issues because In his mind, his purpose for living was to give back. And suddenly, he was in this position where all he could do was receive. And that was so hard for him. He wanted to just die because he couldn't go and take care of everybody the way he had. I think, though, sitting in with him with some of those visits and getting to know him better, that was his last journey, was learning how to receive the love and care that he had given so freely for so many years. And he died just surrounded by people who loved him. And it was beautiful. It was really beautiful.
Fantastic story.
Yeah.
Thank you.
You're welcome. Any other questions?
Thanks for the memory.
Thank you.
Thank you. It was a pleasure.
very much.
Rainy afternoon. Burning toast and prunes.
How lovely it was. Thanks for the memory of candlelight and wine, castles on the Rhine.